Now, I next call upon Dr. Prakash. He is the medical director and chief HOD of the Vitreoretinal department at Comptrust Eye Hospital.
Good morning all, and thank you Rahul for this opportunity. So my talk is a treatment algorithm for diabetic macular edema. So as we all know, DME is a major cause of moderate visual impairment, and the sad thing is it happens in the productive age group of the people, and that affects their productivity a lot. The problems we face in managing DME are mainly late presentation, inadequate referrals, lot of comorbidities in this patient, and we all know DME does not respond just like RVO or AMD to anti-VEGF injection. So the poor response is a variable response. Complaints on the part of patients because of the long-term follow-up and multiple visits that are involved, and of course financial reasons. So the treatment starts with, oh, sorry. Okay, so the treatment always starts with a careful ocular examination as well as history taking. We can never, the importance of history taking is cannot be overemphasized, because many times patients have, we have to always look at that drug history is very important. Drugs like glitazone can make macular edema very resistant. Sometimes many of these patients may be on anti-cancerous drugs like MEK inhibitors, which can actually mimic macular edema, also worsen macular edema. Always look at uncontrolled hypertension is many times common because many physicians overlook hypertension. And always look for these subtle signs like disc pallor, thin attenuated vessels, and these discrete hard X rates that you see here. This all can tell you that there is an underlying CKD with anemia going on. These patients may be having recurrent hypertensive episodes also. And this kind of atypical hemorrhages that you don't see, white-centered hemorrhages, flame-shaped hemorrhages that you usually don't see with DME, should always make you think of other blood dyscrasias that are going on, like leukemia. And FFA has to be done. It should be part of the evaluation whenever you suspect an unexplained vision loss due to macular ischemia, or in cases where you have mimickers like this. Macular telangiectasia is a very common mimicker. It can happen in diabetic patients. It can happen along with diabetic retinopathy. So this type of maculopathy, where it might look a non-center involving diabetic macular edema, will look like a center involving maculopathy because of telangiectasia. Also ocular ischemic syndrome also you have to keep in mind. OCT is most important tool, treatment decision making, retreatment, when to stop treatment. All this depends on your OCT finding, and it will also, there are prognostic clues like bridging retinal process or drill changes that will tell you, that will explain, with which you can explain to the patient so that you can increase the compliance of the patient. So coming to proper managed treatment aspects, we will see some clinical scenarios. This can be one scenario where you have a non-center involving macular edema, but there is some hard X rays and thickening outside the center. And in these cases, if the vision is good, you can safely observe these patients with good follow-up. If the vision is affected to some extent, but better than 6/9, and if you feel this is due to the macular edema, and if the macular edema meets the CSME criteria, then you can do a focal laser to the microaneurysms, which are within 500 to 3000 microns from the center of the fovea. So don't do a grid laser, always do a focal laser to these microaneurysms. This is a very common scenario. Actually, one study showed that about 80% of the patients have 6/12 or better vision, even though they have center involving DME. So center involving DME with good vision is a challenging thing, and especially these kind of pictures we see very common where there is a central foveal cyst. So the studies like Protocol V has clearly shown that if you either you can do observation or you can do focal laser or inject, the results are the same. So it is always preferable to observe these patients, and if they develop a drop in vision, then you can of course think of starting them on treatment. Or if a patient is symptomatic like metamorphopsia or something is there, then you can think of treating the patient. This is the center involving DME where the vision is already affected. Here always the first line of treatment is anti-VEGF injection. You have two protocols you can follow. Either the DRCR protocol, which is most commonly followed, where we inject monthly continuously till maximum improvement. Less than 10% improvement is achieved. So like if one injection, after one injection, if there is an improvement which is less than 10%, then you consider it as no improvement. And at that point of time, you can hold the treatment of the patient. And there is no vision improvement also. Both criteria should be met. No less than 10% improvement and no visual improvement. Then you can hold treatment but continue follow-up monthly initially. If there is no recurrence, slowly increase the follow-up period by 2 weeks till maximum of 4 months. So if there is no recurrence, you can continue observation every 4 months. But if there is a recurrence, again you have to switch back to the treatment. And this is another scenario very commonly which we face. We have treated the patient, there was good response, but at one point of time it's not further responding. There is some residual macular edema. Here what you have to do is you have to look whether there is any microaneurysm which is visible clinically, or there is any fresh circinate exudates, or there is a leak on an fluorescent angiography. If any of these present, you can treat them with focal laser and stop treatment. And also stop treatment, don't further treat if there is a subfoveal clump or plaque under the fovea. Then recurrent DME, this is you have treated, patient has responded well, gone back to the end point, but patient recurred after stopping. Here what will you do? Here it is always better to start treating with the same drug which you have injected before, for which it has responded. No need to switch treatment. Then comes non-responders, like this case where after injection actually it has worsened. Non-responder is a very difficult definition because many clinical trials has asked us to wait for 6 injections before we call them as non-responders. But in a real world scenario, we would call them as non-responder after 2 to 3 injections if we are seeing either less than 10% improvement or less than 5 letter gain in vision. Then it is known as a non-responder. Here your option is either you switch to another anti-VEGF. There is no rule that one anti-VEGF, it is not working, another won't work. So you can, if you are injecting bevacizumab, you can go to ranibizumab or you can go to aflibercept. Otherwise, you can think of giving steroids also. But the most important thing, if you see a non-responder, is always revisit the systemic status of the patient. See any new drug has been added by the physician. Also, I make it mandatory to get a complete hemogram, CRP, ESR, peripheral blood smear, HB, BP, and in very suspicious cases, get a serum electrophoresis because multiple myeloma, gamma globulinemia, can mimic resistant DMEs. And when do you consider steroids? That is one common situation is responding to anti-VEGF, but patient cannot follow up with you, they are going to gulf or something, then those patients can be converted to steroids. Pseudophakic patients who have reached a plateau with some persistent intraretinal fluid, steroid is an ideal drug before stopping the treatment. Persistent edema patient needs cataract surgery, steroid. And eyes post vitrectomy also, steroid is a good option. And in patients who have systemic thromboembolic events while on anti-VEGF can also be switched to steroids. When do you consider vitrectomy? When you see a vitreomacular interface disorder, like here you can see a thick hyaloid which is developing, which is getting detached, and you see once after injection, still you inject these patients. Don't directly go for surgery, still you can inject, but if there is no response, you see actually it is worsening after the first injection. So those cases you can consider vitrectomy. And with vitrectomy, as you see in the last picture, with vitrectomy it improves, but many times vision may not improve. Macular edema resolves with the vitrectomy. And for DME without any vitreomacular interface disorders, evidence shows that vitrectomy does not help. So you have to continue, option is only to give injection. With PDR DME is a very common scenario which we face. Always start anti-VEGF injections with in the DRCR net protocol. Just 1 minute. In the DRCR net protocol pattern, and don't forget to stop, to do PRP when you stop injecting, because when you are injecting, the new vessels disappear, even the background retinopathy disappear. This will give you a false sense of security that your DRSS or the diabetic retinopathy severity score has decreased, your PDR has gone to moderate and PDR you might feel, but don't feel that, because these patients have supraphysiologic worsening of diabetic retinopathy when you stop injection. So they will suddenly progress to rubeosis or PDR. So always don't forget to do PRP once you have reached the end point with injections. And when you have large predominantly vascular NVEs, always start, when the NVEs are very big, then start with PRP, fractionated PRP, small sittings away from the NVE, at least 4 disc diameters away from the NVEs. Then at the end, if macular edema is persisting, then think of injecting. And NVI alone, start with injection and complete with PRP. So this was the case, these are the types of cases. You have the clinically these new vessels are not visible, but on angiography you can see large flat new vessels. What happens is if you inject, then they develop what is known as crunch syndrome, sudden contraction, sudden fibrovascular switch of the new vessels, which will cause the fibrous contractions around the macula and the macular TRD. So don't inject in this case, always do PRP before injecting. And center involving DME in post PRP, this is also very common. Even though 40% of the patients angiographically develop CME after PRP, only 25% require treatment. So in these cases, actually the response to anti-VEGF is poor. Steroids may be a better option. And in cataract surgery, you can always combine, if there is macular edema, combine with an intravitreal steroid or anti-VEGF. And if there is a post-cataract surgery worsening of DME, always think of pseudophakic CME. Also do an angiography, rule out pseudophakic CME. A hot disc and the petaloid pattern will tell you that this is pseudophakic CME, so the treatment is totally different. Otherwise, if it is, you see the microaneurysms leaking, then you think of DME and start the same protocol as you do in a normal DME case. And in pregnancy, anti-VEGF has not proven its safety, so it is always, if the vision is affected and there is a center involving DME, steroids has to be given. And sometimes spontaneously after delivery, macular edema has been shown to improve also. Systemic factors, never forget to control, because studies have shown that HbA1c control alone won't resolve the macular edema, but the response to anti-VEGF drugs is much better when the patient's HbA1c improves. So always think of anemia correction, blood BP control, all those issues. So to conclude, real world scenario, DME treatment still remains suboptimal for many reasons, as I told, like difficult follow-ups, poor referrals, and some extent complacency from the part of doctors or patients also contribute to this problem. So every attempt should be made to optimize the treatment. We have to minimize the visits and financial loss for the patient. At the same time, we have to try to preserve the vision for these patients. Thank you.